The management and safety interview is administered at the 1-week telephone call, at the 4-week visit, and at the 8-week visit. I'm still working on it. I'm hoping it can go to committee in the next couple of weeks. I'm still not sure if we're going to do it for the 11-week telephone call, because that's really a closeout and it's somewhat different kinds of questions. But Julie and I are talking about that because she was working on the 11-week phone call interview. It's going to be a standard kind of interview. So there are safety items that ask about the adverse and serious adverse effects that we're monitoring. Based on their responses, there will be guidelines about whether a specific response warrants referral to a study clinician, the primary care provider, discontinuing study pills, that sort of thing. There are the management, which is my euphemism for adherence, items that ask about pill taking and any problems or barriers that they're having to the pill taking. And based on their answers, the staff person could discuss adherence strategies, ways to overcome the barriers, helpful comments. And depending on if she's having sort of problems remembering her study pills, or maybe some symptoms that's making her think, I'm just not sure I want to hang in there with these study pills. Hopefully that won't happen, but if so, I think you might want to consider a non-routine contact in which you might call her back in a week or so to see how she's doing now, if she's indeed having some issues, just to make sure that things are going okay and she's staying on the study pill regimen. This is also an opportunity for the participant to identify any other sort of study-related concerns that she's having. It's a fairly interactive discussion, and so other things may crop up, and you may want to have some guidelines at your own clinic about, depending on the kinds of concerns she raises, who might, who she should be referred to, or what kinds of things you might want to say. Questions about that? You're all ready for lunch, aren't you? So at closeout, which is for most participants the 8-week visit, if they're taking 1 pill a day, they would discontinue the study pills right away. But if they're taking 2 pills a day, as you know, they would be tapering. So it's not quite the closeout of stopping study pills for them, and this is the regimen for doing so. So you would want to reinforce that as you're going over the management and safety interview. And then I'd like to talk a little bit about adverse events, which isn't something we like to think is going to happen, but they do need to be monitored. There are specific definitions for what is an adverse event versus what is a serious adverse event. Adverse events are untoward or unfavorable medical occurrences that happen during a study, and they may or may not be related to the intervention. Whereas a serious adverse event is an adverse event that might result in death, it's life-threatening, or places the participant at some sort of immediate risk of death, requires prolonged hospitalization, or causes persistent or significant disability or incapacity. And you can, I hope, appreciate that these are terms coming out of official NIH guidance. In fact, the National Institute on Aging has a really nice sort of informational guidance about dealing with adverse events. So for this study, adverse events are generally managed by the participant or the primary care provider as desired, and that's when I mentioned those symptoms that she might self-manage alone, or if self-management strategies aren't working, she might want to talk to her primary care provider. The serious adverse events are generally managed by the primary care provider, but it might be an urgent referral. The study pills might be discontinued, and hopefully somebody is addressing that adverse event before she calls the clinic, as opposed to the clinic having to address it. But sometimes staff at the clinic are put in that position of needing to sort of say, you need to call 911 or go to an emergency room or something, depending on what the adverse event. What comes with that is that a serious adverse event form, which is also in development, would be filled out, and that's sort of an expedited report that we're saying you can turn into the DCC, and we'll make sure that it gets out to the DSMB and the NIA based on what is required. However, your IRB may have specific requirements about reporting as well. And so we're going to sort of leave it to you that if your IRB requires 24 to 48 hour notification of a serious adverse event, then you would want to do that. The serious adverse event form should be initiated and reported to the DCC as soon as you hear about an adverse event. But as you can appreciate, sometimes the details, the disposition, how it's handled, and what sort of ended up happening takes a while. And so in addition to the sort of 24-hour report, once those details are available, you would fill out the form in much more detail and send it along to the DCC, and that would also go to the various groups like the DSMB and the NIA. The way those adverse event forms are sometimes used is in one way to see if there's anything about study procedures that might need to change, but also it's informative to learning more about this treatment, particularly in this population.
I have a couple questions. Excuse me. So you mentioned that the DCC will be handling the reporting of serious adverse events to the NIA and DSMB. Will they also be reporting to Forest, or will we need to be doing any of that serious adverse event?
That's a question that I don't know. Leslie's shaking her head.
I'm shaking my head. I don't know for sure, but I think our legal requirements are to go to the NIA and the DSMB, and anything that would go to the manufacturer, we can look in the details of how that.
There isn't an IND for this study.
Yeah,
that's right.
However, I know that there is a drug donation, so they may want to know about.
Yeah, it's just the method and
Yeah.
the mechanism for notifying.
Yeah, I
They
have
want
a
to be
somewhat
consistent with it.
different question, which is generally one of either the PI or the site physician indicates on the adverse event form whether or not they believe the event is related to study
The
medication.
treatment, right.
Right.
And actually, that's the case for the adverse events as well. But
Right, but
Yeah.
it's at a little different
Right.
level from, the serious adverse events. And I don't know whether in this study you all want any, again, it's a small study, but any general review of those to see if sites agree that.
Sometimes it's IRB dependent,
Well,
because the IRB says we don't want
amazingly,
that.
I have a study that the PI consistently says the event is not related to the study medication, and her IRB doesn't want to see it.
Right.
So
They don't
and
want to-
it's one of the
they
reasons
don't
I
want to
sort of
see
feel
that
like one of the
question
things
about
that we
it.
can do for you as a DCC
Yeah.
is reporting requirements that cut across all groups, rather than you having to send multiple reports if you just send it to us. But your IRBs may have something very specific, and that's something we can't necessarily address. So if Fisher were to decide they want to be notified on any
Forest.
Forest, on any serious adverse event, we can do that. We can make that referral. The issue of deciding whether it's due to the study drug or not, to some extent, depends on getting that more detailed information. And so that might not happen right at the 24-hour reporting time.
As far as notifying Forest, if that happens, I mean, my point in shaking my head is that it's not my understanding that the network sites would need to do that. You just need to report to the DCC, and then we work with NIA and get it all.
So anything quirky, we're going to leave to you. But anything that's sort of study-wide, we'd like to sort of facilitate that happening to make sure that it happens.